Hi everyone, Dr. D'Amato here. I wanted to put together a brief PowerPoint presentation just touching base on some of the drugs used for conditions involving the respiratory tract. There are so many conditions, so we're going to pick some common ones and go over the drugs used. You can find more in-depth references in your textbook, and I really encourage you to view the videos. I have chosen them each individually because I feel that they have great merit for your learning process. So take the time to view or listen to those videos. Download them on your phone, listen to them in the car. I think you're going to find that they will be very helpful. This slide speaks to asthma, and asthma is an inflammatory process of the bronchi, chronic. It usually is triggered by precipitating factors like an exposure to something that the patient may be allergic to or be sensitive to. It's not progressive unless it's left untreated. If it's left untreated, then you may end up with scarring and issues, and actually it is on the higher end of causes of death due to it not being treated properly. So I really want you to watch that video that I posted on asthma because it does a great job of differentiating the treatment modalities between asthma and COPD because they actually go in opposing order. With asthma, we're always going to start with a short-acting adrenergic agonist, albuterol. That's pretty much the go-to. Xopenex is used a lot. The problem with Xopenex is a lot of insurance companies don't use it. I prescribe Xopenex to people who may have some issues with heart palpitation. A lot of people, once they use that albuterol inhaler, they get like shaky, their heart's beating really fast. Xopenex, they're not going to have that. It's a different formulation, but it's more expensive. So I'm finding a lot of insurance companies are giving me some pushback about prescribing that. And those are both prescribed for asthma and COPD. If a patient is using their albuterol inhaler more than twice a week with asthma, they are not controlled. Then there's the long-acting adrenergic agonist. Again, we're going to use these for both COPD and for asthma. Remember, they always end in an R, or excuse me, an OL. And then there's the inhaled corticosteroids. We use these for asthma, COPD, and also for people who suffer from allergic rhinitis. And you may recognize the names of Qvar, Rhinocort, Flonase, Flovent, Nasonex, Nasacort. Then there's the long-acting adrenergic agonist corticosteroid combination. We'll see these used a lot in both asthma and COPD, the chronic asthma patient, and those you'll see by the name of Symbicort, Dolterra, Advair, Breo. Then we have a short-acting anticholinergic, Atrovent. This is used in allergic rhinitis and COPD. It is not something that you typically are going to use for asthma. Then we have the long-acting anticholinergic. These are used for COPD. Leukotriene modifiers are used in asthma and allergic rhinitis. Now, these are for people who suffer from allergic asthma. It binds with the leukotrienes, which is a chemical mediator produced in the lungs, which promotes inflammation. Then we have our antihistamines, Zyrtec, Astelin is a nasal spray. We use that in allergic rhinitis and also allergic rhinitis, allergies. Zysel is not on the list. I like Zysel a lot. It's my first line choice for those who have stubborn allergies. I just find that it works better on those patients who have trouble getting relief. Then we have our adrenergic agonists, and those are your decongestant nasal sprays and decongestants. These are the ones that are contraindicated in hypertension because they can cause your blood pressure to go up. Astelin, wrong one. Afrin, Dristan, neosynephrine, Sudafed. So those are the most common. You'll see this in patients who are experiencing allergic rhinitis. Now, I tell my patients who come in with allergic rhinitis and they say, well, I don't know what to take. I want to take something over the counter. Okay. Antihistamines are dryers. Okay. They dry things up. So if you're drippy, take an antihistamine. If you're congested, take a decongestant. If you're both, then take a combination. You can buy Zyrtec D, you can buy Allegra D. All those things come in D's formulations. Now, the problem with antihistamines is that they're good at drying you up, but they can also dry you up too much. The same thing with decongestant nasal sprays. So you don't want to use an Afrin or a Dristan nasal decongestant spray for longer than 3 days, or it is actually going to counteract the effect. For coughs, I have to tell you honestly, there's nothing that works really good on coughs. Benzenate, this is a prescription. It's called Tessalon Pearls. It can help to alleviate that tickle cough that people with postnasal drip can get in the back of their throat. Codeine with guaifenesin. Cheritussin is the most common. It has an expectorant in it. And remember, anytime you're administering codeine, the reason that it's working on the cough is because it is suppressing the respiratory center in the brainstem. So, I don't really like to use that too much. But back in the olden days, doctors prescribed it all the time, even for children. But no way, not today. Then you have dextromethorphan with guaifenesin. Guaifenesin is a fancy word for Mucinex. I will use something called promethazine dextromethorphan. So it is promethazine, which I'm sure you administered in the hospital. It doesn't have a narcotic in it. It can make you a little drowsy though. And then the DM helps suppress the cough. I find that out of all of the non-narcotics, I have the best result on my patients when I use that. Then there are other agents like Nasocrom, Xolair, Roflumilast, and Theophylline. Theophylline is done for asthma. Rarely. I haven't seen it used in years and years and years and years. A lot of nasty side effects from it. But it's still out there, so maybe somebody's using it. They have come out with some great biologics now that will work for eosinophilic asthma. So it actually helps prevent the proliferation of eosinophils in the allergic patient and is greatly helping people who have chronic asthma. Okay, so let's go into the mechanism of action a little bit in more detail. Okay, so we've got our beta adrenergic agonists. It activates beta receptors on the bronchial smooth muscle, and it can cause tachycardia, hyperglycemia, hypokalemia, hypomagnesemia. Most common names, it has a rapid onset, and then long-acting, we have the formoterol, and then all of those alls. Prolonged duration of effect, but a delayed onset controller medication. So those long-acting beta agonists, or the LABA, they should never be considered short-acting. So that's not a rescue inhaler. That's something that you use in concert with your rescue inhaler. All right. Then we have our corticosteroids. This is used for long-term control, and here's some names: the beclomethasone, budesonide, fluticasone, mometazone, and it works by direct anti-inflammatory effect. So it minimizes the effect of inflammation. It can cause yeast in the mouth, and you can use oral or IV or IM therapy in exacerbations. So we're going to use our inhaled steroids. If you have an exacerbation, then we're going to bump it up to an oral if we have to. Leukotriene modifiers. This is your montelukast. I don't see the second one used very often. Zafirlukast. In fact, I never see it. I only ever see montelukast, or the name used to be singular, but it's in generic now. So, and this little diagram shows the mechanism of action at a physiologic level. Other treatments, we've got cromolyn. Again, I don't see this in practice often. It inhibits mast cell degranulation and histamine release. It's used in a nebulizer. It's short duration of action. Ipratropium blocks bronchoconstriction and mucus secretion mediated by the mucineric receptors. And again, that video that I posted goes into such wonderful detail on those receptors. We use it in acute asthma exacerbation in conjunction with a short-acting beta agonist, and it's used in COPD as well. Theophylline, again, I said we don't use this, and I haven't seen it in practice. Perhaps you have. But it has a lot of nervous side effects: insomnia, GI discomfort, seizures, arrhythmias, headaches. And it also has that CYP1A2 and CYP3A4 substrate, so it interacts with a whole ton of different drugs. Now, here's the one I was talking about before, Amelzumab. This is that biologic. It's a recombinant monoclonal antibody that binds to IgE and inhibits it from activating receptors on mast cells and beta cells. They're using this in eosinophilic asthma. They use it a lot. I mean, these things are really finding people who have autoimmune disorders that these biologics are incredibly effective, but they are also incredibly expensive. And they can cause anaphylaxis, arthralgias, fever, rash, malignancy. It also makes you more prone to developing infection. But they have really changed people's lives. They're that effective. Asthma clarifications: intermittent, mild persistent, moderate persistent, and severe persistent. And then each area of the graph illustrates what we're looking for. Now, I am a big believer in peak flow and spirometry. So when you get into practice, you have patients who have asthma, you should be doing their daily peak flows, or having them do daily peak flows, and then when they come in, having them do peak flows in the office. So get into that habit of doing peak flows, and I think I'll post something about peak flows so that you have an idea of why they're so important in the treatment of asthma. Tiotropium. This is a cholinergic antagonist, and this is a controller medication for both COPD and asthma. It's a capsule that's punctured and then inhaled. You inhale the spray from it, and it is one of the names for this is called Spiriva. And you may think, oh gosh, you're inhaling this powdered substance, but it actually is very effective, and it can get into some areas that the inhalation sprays cannot. All right, the next one is Roflumilast, and I have to say I don't see this used very often. Maybe maybe you have. This is an oral phosphodiesterase diesterase 4 inhibitor. So it is theorized to reduce inflammation by increasing intracellular CAMP. In our video, we talked about CAMP and how when a patient has asthma, we need to up the CAMP, right? So if it works, that would be a great thing. It reduces exacerbations in patients with chronic bronchitis. It can have some nausea, vomiting, diarrhea, and headache. But again, I don't see this. I haven't seen it in practice. And that concludes our presentation. Again, as I said at the beginning, there's so many drugs related to the pulmonary system, and asthma is something that you are going to be working with a lot in practice. So that's one of the reasons that I focused so much on asthma and COPD in this presentation. Please let me know if you have any questions or if there is anything that you would like me to go into more depth, and I would be most happy to do so. Well, I decided to add a couple of slides. So here they are. Allergic rhinitis. And I wanted to add this because you're going to see this a lot in practice as well. Many people think allergic rhinitis, they need an antibiotic. This is the big, I deal with this every day that I'm in clinic. Allergic rhinitis. There's also just the diagnosis of rhinitis, which rhinitis in itself can be allergic in nature or can be viral in nature. We treat it with antihistamines. And again, as I said earlier, if the patient is very drippy, let's try an antihistamine. If they're very congested, let's do a decongestant. If they have both, then let's use both. Second generation antihistamines are usually better tolerated. That's your Zyrtec, your Claritin, Allegra, and Xyzal. Benadryl makes you so tired. I always have my patients use an intranasal corticosteroid, Flonase or Nasacort. It's now over the counter, and reducing the inflammation in those nasal sinuses is so important. But it's also important to advise the patients, this is not like a nasal decongestant where you're going to squirt it in your nose and you're magically going to feel better in 10 minutes. Flonase and Nasacort work over time. So it's going to take at least a few days before they start to see the effect from the nasal spray. But they have to continue to use it. And as I had said earlier, you don't want to use a nasal decongestant more than 3 days in a row, or it can cause rebound congestion. Cough. I covered this already, but I just thought I wanted to make a slide about it. Opioids decrease the CNS sensitivity to the cough. We have addictive potential, and dextromethorphan is a synthetic derivative of morphine with a lower addictive potential. So I try to steer clear of opioids. I prescribe them once in a while, but not often. Guaifenesin, I like to use guaifenesin. Everybody who has a bronchitis, sinusitis, I advise them to take guaifenesin, but guaifenesin is like that Flonase. They're not going to take it and say, oh my gosh, I feel better. Guaifenesin has one job and one job only, and that is to thin secretions. So number one, the patient has to have enough fluid on board, and or else it's not going to work. So they need to stay really hydrated, and it's going to make it easier for them to get rid of the mucus either by blowing it out, spitting it out, or it will go down the back of their throat into their stomach. Guaifenesin, I have all of my patients take it when they're sick. And benzoate, which is the Tessalon, it helps with the cough reflex. Minimally, I have some patients who love it. I have other patients who would rather not take anything. It does nothing. It can cause numbness of the tongue, mouth, not moth, and throat. Those are the most common side effects of it. But as I said before, I have some patients who absolutely love it. who ask for it, and others where I took that capsule and it didn't do anything for me because it comes in these little capsules. All right. So unless I add something later, this will be the end of our presentation. And again, please, if you have any questions or comments, reach out and I would be happy to expand on any of these topics.